roof of the mouth, and guide it downward. Continue advancing the device until you feel resistance, which indicates the distal end of the tube has reached the hypopharynx. Withdraw your finger and inflate the mask. Once inflated, the laryngeal mask airway will center itself in the mouth. If placed correctly, oxygen will flow through the lumen of the device and into the trachea. The laryngeal tube is a supraglottic device that can be inserted in an unconscious patient. Providers can insert the device during CPR while chest compressions continue. The device can also be inserted without visualizing the glottis. The laryngeal tube is a single lumen device with two cuffs inflated through a single inflation port. The distal tip of the tube is angled and beveled to easily slide into a collapsed upper esophagus. The design also reduces the likelihood of tracheal insertion. When the tube enters the esophagus, you should feel resistance. Inflate the cuffs with a single syringe. The esophageal tracheal tube is a supraglottic device that providers can insert during CPR without interrupting chest compressions and without visualizing the glottis. The esophageal tracheal tube is made up of two lumens permanently joined. Each tube can be used to provide oxygenation and ventilation, depending on how it's inserted. The longer blue tube, marked with a number 1, provides ventilation through 8 small side openings of the lumen in the pharyngeal section. The shorter clear tube, marked with a number 2, provides ventilation directly through the lumen to the end of the tube. Once the tube is in place, use the large blue syringe to inflate the pharyngeal cuff through the port labeled number 1. Then use the smaller syringe to inflate the distal cuff through port number 2. The distal tip of the device will rest in either the esophagus or the trachea. If the tube rests in the esophagus, which happens most frequently, the cuff blocks airflow in and out of the esophagus, and ventilation occurs via lumen number 1 and through the small side openings into the trachea. If the tip of the tube comes to rest in the trachea, however, the rescuer can use lumen number 2 to deliver ventilation directly into the trachea. Caution: it's critical to confirm the proper placement of the esophageal tracheal tube, because if ventilation is delivered to the incorrect lumen, it will prevent adequate oxygenation and ventilation and result in severe hypoxia. Incorrect delivery of ventilation to the esophagus will also produce gastric insufflation that will complicate ventilation. The endotracheal tube was once considered the optimal method of managing the airway during cardiac arrest. However, intubation attempts by unskilled providers or by providers who use it infrequently can produce serious complications, such as trauma to the oral pharynx, incorrect placement in the esophagus or right main bronchus, and prolonged interruptions in compressions and ventilations. Despite the risks of intubation in inexperienced hands, there are many benefits to endotracheal intubation. These include keeping the airway patent, allowing suctioning of the airway, speeding the delivery of high concentrations of oxygen, providing an alternative route for some drugs when intravenous or intraosseous routes are not available, and when using a cuff, potentially protecting the airway from aspiration. The endotracheal tube is a single clear lumen with a single cuff. To insert the endotracheal tube, place the patient's head in the sniffing or neutral position. Insert the laryngoscope blade into the patient's mouth. Lift the laryngoscope vertically up and away to expose the vocal cords and glottic opening. Insert the endotracheal tube directly between the vocal cords and into the trachea until the cuff passes the cords. Once the endotracheal tube is in place, inflate the cuff and attach a waveform capnography monitor to confirm proper tube placement. When choosing to use an advanced airway, you need to be confident that it is inserted correctly and that you're providing effective ventilation while avoiding excessive ventilation. Watching for chest rise, checking for bilateral breath sounds, and listening for gurgling sounds coming from the stomach can help you confirm the placement of an advanced airway. Beyond these clinical assessments, there are several devices that can help you determine whether you have inserted the airway correctly. Waveform capnography monitors how much carbon dioxide is exhaled by the patient. The American Heart Association recommends using waveform capnography to confirm and monitor the correct placement of an endotracheal tube. Effective ventilation through supraglottic airway devices should produce a capnography waveform. A normal end-tidal CO2 waveform looks like this. The measurement of the amount of end-tidal, or exhaled, carbon dioxide can be shown as a waveform, where the carbon dioxide level goes up when we exhale and falls back to zero when we inhale. Even when healthcare providers are properly ventilating the patient, chest compressions will produce a low-end tidal CO2 reading because even the best CPR produces cardiac output and pulmonary blood flow that's about 25 to 30% of normal. In contrast, ROSC can cause an abrupt increase in end-tidal CO2. Waveform capnography devices that display both a waveform and a number will give you the most comprehensive information. Connect the monitor between the advanced airway and the bag or ventilator. Waveform capnography provides a graphic demonstration of the carbon dioxide exhaled with every breath. Humans with healthy lungs have a characteristic waveform that is divided into 4 phases that occur during inspiration and expiration. When the patient first begins to inhale, the curve falls sharply to 0. As the patient continues to inhale, the reading on the monitor should remain at 0. When the patient first exhales, the initial portion of the breath consists of the air in the dead space from the breathing tube and the trachea. As air from the alveoli begins to empty into the circuit, carbon dioxide levels start to increase. This is shown as an upward deflection at the beginning of the exhaled carbon dioxide curve. As exhalation continues, carbon dioxide continues to pour out of the lungs until the next breath is initiated. The highest value in the curve is called the end-tidal CO2. For patients with normal perfusion, an end-tidal CO2 reading of less than 35 millimeters of mercury indicates hyperventilation. A reading of more than 45 suggests hypoventilation. In the patient with adequate circulation, the key uses for waveform capnography include the placement and monitoring of an advanced airway and the management of ventilation support. In cardiac arrest patients, waveform capnography reflects the effectiveness of chest compressions during CPR, and a sharp increase in end-tidal CO2 signals the return of spontaneous circulation. The higher the end-tidal CO2 pressure, the higher the cardiac output is during resuscitation. An end-tidal CO2 of less than 10 millimeters of mercury suggests that the cardiac output is insufficient to achieve ROSC. If the CO2 readings are low during resuscitation, the team should optimize CPR quality by minimizing interruption in compressions, delivering compressions at a depth of at least 2 inches and at a rate of at least 100, but no more than 120 compressions per minute, allowing complete chest recoil and avoiding excessive ventilation. Sudden changes in the waveform should trigger immediate reassessment of the patient. When the waveform jumps up during resuscitation, this may indicate ROSC. A sudden drop in a waveform of 20 points or more could indicate a sudden, severe decrease in cardiac output that might be caused by a pulmonary embolus, acute blood loss, or life-threatening arrhythmia. A decrease to 0 indicates no gas exchange or no carbon dioxide delivery, such as occurs with a displaced endotracheal tube, or the sudden stopping of blood flow, such as occurs with ventricular fibrillation. A rising baseline in the end-tidal CO2 waveform suggests that carbon dioxide is re-entering the side stream sampler during the inspiratory phase of ventilation. This reading might indicate that the patient is rebreathing carbon dioxide. This waveform has a prolonged phase 4 or inhalation section. This suggests that there's air entering the trachea beyond the entryway that's being monitored. This happens if the cuff on the tube is deflated or if the tube is too small for the patient. In both arrest patients and post-cardiac arrest patients, ventilation and perfusion must be optimized to prevent lung injury, cerebral ischemia, and cardiogenic shock. The use of waveform capnography can dramatically enhance your ability to manage cardiopulmonary patients. Another type of CO2 detector, the colorimetric end-tidal CO2 detector, simply changes color when it detects CO2. One additional confirmation device is the esophageal detector device, or EDD. The EDD is a bulb that providers compress and attach to the endotracheal tube. If the tube is in the esophagus, the bulb will not re-expand and fill with expired CO2. An alternative model is a large aspiration syringe attached to the tube. If the endotracheal tube is properly placed, providers will have no difficulty retracting the plunger. Esophageal placement will prevent plunger movement. Airway skills are fundamental to successful ACLS. Proper training, frequent practice and use, and logging both successes and complications can help build your skills and lead to more comprehensive, successful patient care.
All right. Go to lunch.